Today, I'll talk about a non-AIDS defining cancer in HIV-infected patients in Japan. So first, I'll talk about why I'm focusing on the non-AIDS defining cancer first. So this is my COI in the past 3 years. So the epidemiology of HIV was already presented by Dr. Shirasaka. So please look here, the total number. In Japan, total number of HIV patients is 30,000. And this is the annual new and cumulative HIV cases in AIDS Clinical Center by the end of 2017. We have around 4,385 cases registered. And this number means the 1 in 7 HIV positive patients in Japan were registered at our AIDS Clinical Center. So this slide shows the trend of the ART in AIDS Clinical Center over time. Around 2000, we used the efavirenz-based ART. But recently, we don't use this drug because of the severe CNS side effects. Then we switched to the PI-based ART around 2005 to very recently. But again, the problem of CVD or bone mineral density loss getting important. Then recently, we used integrase-based ART. And this is the CD4 count at the first visit in 2017. So nearly 40% of them, CD4 count is less than 200 at the first visit. And look at here, in the past 3 or 4 years, almost the same. Nearly 40% had a very low CD4 count, and only 15% of them had a very high CD4. And look at here, almost the same trend. But when we look at the CD4 count on ART in our AIDS Clinical Center, most of them had CD4 count more than 200, and more than half of them had more than 500. And if we look at the viral load, so nearly 85% of them had a viral load below undetectable. And if we look at the less than 200 copies, most of them achieved viral suppressions. Combined with the CD4 count and the viral load, most patients are very well controlled with current ART in Japan. And this is Japanese data, the survival curve. This is the survival curve that includes all cause of death, not only AIDS. But look at here, from 8 years, the prognosis of HIV patients are drastically improved in Japan after 2000, like other developed countries. So this slide shows the age of ACC at the end of 2016. At that time, 34% of them, outpatients, were over 50 at the end of 2016. That means the 2019, more than 35% of them had aged over 50. So the aging is getting big problems. And this slide shows the comorbidities observed in HIV-positive patient. So this is hypertension or hyperlipidemia, CKD, and diabetes. So along with aging, so HIV patient had a high rate of the lifestyle-related diseases. And again, in addition to these comorbidities, we should consider the cancer in HIV-positive patients. So this slide is a DAD cohort study. This slide is published in the Lancet in 2014. In DAD, some huge number of the patients are followed, and nearly 4,000 deaths in DAD cohort. In this cohort, nearly 30% of them died from AIDS-related, but next one is non-AIDS defining malignancies in here. And this is also the DAD data. So this is the annual change of the mortality since around 2000. So most of the cause of death is decreasing, like here, but only NADM, like here, is very stable or a little bit increasing. So this table shows the cause of death in AIDS Clinical Center in 2016. So if you look at that red column here, gallbladder carcinoma and ALL and colon cancer, esophageal cancer, and lung cancer. So among 19 deaths, 5 cases died of NADM. So nearly the 1 in 4 deaths. And look at the yellow column. It's caused by the AIDS death, cryptococcal meningitis and lymphoma, and this case is died of AIDS. So we summarize the last 3 years. So 70% of them die of AIDS, but 28% die of NADM, and nearly 30% is caused by the mental health-related deaths. So the cause of death have been changing from AIDS to NADM or mental health-related. And this slide shows the relative increase of NADM in ACC. Around 2000, 80% of cancer is caused by the AIDS-related, like KS or lymphoma. But recently, most of them caused by the non-AIDS defining malignancies. So the pattern is changing recently. And this slide shows the status of ART. For example, in non-Hodgkin lymphoma or Kaposi sarcoma, so-called AIDS-related cancer, most of them diagnosed before ART. But you can see here, NADM. So most of the cases, 70% of the cases are diagnosed during on ART. This is a very big problem because I presented before that the patient on ART had a very high CD4 and very low viral load, but still we have to care for the non-AIDS defining cancers. This is the age at diagnosis of cancer. So the AIDS-related is a little bit younger, and NADM is 55, comparing with AIDS-defining cancer. So the mean age of NADM is higher, looks higher. But if we look at the general populations, the cancer age is over 65 or 67. So comparing in general populations, so the NADM in HIV cases is very, very young. So this is the cause of NADM in our AIDS Clinical Center. So these are the increasing, gives a very steep increase in others. So next slide, we look for these others, more detail. The other one is HPV-related cancers, like here. So we focus on the other cancers diagnosed in recently. So 3 cases of the pancreas, and 3 cases of thyroid, and 2 bladders, brain, skin, gallbladder, and prostate, and the seminoma, and the peritoneum. And these cancers are occurred under 60, like here. So many rare cancers occurred in each age group, not only in the elderly. So very young patients suffered from the NADM, like here. This slide, this is a very busy slide, but I'll show you the anorectal HPV-related infection and precancer status in MSM. So we checked HIV-positive MSM in our outpatient clinic, ACC, and HIV-negative MSM at the sexual health clinic in NCGM. So we checked the pap smear test and high-risk HPV genotypes. And here, anorectal HPV infections in HIV-positive MSM, more than 70% of them had high-risk HPV, and nearly 40% of positive in HIV-negative MSM. And precancer status, that include low cell and high cell, but the 35% of HIV-positive had a precancer status, and 50% is HIV-negative. So looking at these data, both rate of HIV-positive MSM are nearly twice as high as those of HIV-negative MSM. So reasons of differences is accumulation of the aging, or natural clearance are to be elucidated in a longitudinal study in future. And this is an HPV-related cancer in MSM. So far, we only have 70 cases, but look at here. 9 out of 17 cases are very young age, 30s and 40s. So HPV-related cancer occurred in 30s and 40s, and if we think about the very high prevalence of the HPV in MSM, we should think about the increase of the HPV-related cancer in future. So summary of the NADM. NADM has become one of the major causes of death in HIV-infected patients in ART era. And NADM occurs during on ART, and NADM occurs earlier than those in general populations. And many rare cancers have been increasing recently. So in the next step, how to get early diagnosis of these rare cancers is a very important clinical issue. And we should be aware of the HPV-related cancer must be increasing. So I'll talk about a little bit about the cancer screening. So I conducted a study of co-screening for cancer and cognitive disorders using the FDG PET in HIV-infected Japanese hemophiliacs. So we screening with the FDG PET and cancer and cognitive disorders. But today, I only show you the cancer data. So why Japanese hemophiliacs? Because they were infected with HIV at least before 1985. That means they are already infected more than 34 years. So very long history of HIV infection. And median age of them are nearly 50. And almost all infected with HCV, but all cured HCV currently. And long history of ART, first starting with AZT monotherapy and step by step. So they had many drug resistance. And NADM has been increasing in hemophiliac populations. So 81 hemophiliacs were currently coming to our AIDS Clinical Center. And I approached to all of them. And 68 gave us the informed consent and agreed to participate in this study for the first screening. And so cancer screening study is twice in 3 years. So in the second screening, 56 patients agreed to participate in this study. So the method of screening, if positive findings by FDG PET and or chest CT, and still occult blood positive and tumor markers, and for the biomarkers, we examined a couple of tumor markers like here. And if one of these are positive, we'll do the responsible specific examinations to confirm diagnosis, such as colon fibroscope or abdominal CT, MRI, or echocardiograms that depend on the positive in these screening. So this is the result of the first screening. We found 4 patients with NADM among the 68 study participants. That means the prevalence was 5.9%, mean age of the 45.8 years. So this is a detail. One is the thyroid papillary cancer. So in this case, there are already operations. And second one is thyroid follicular cancer. Again, already removed. And third one is probably suspected with the papillary cancer, but he refused to further examinations. But very strongly suspected. And one case is a neuroendocrine tumor. And so we found 4 cases, but we had 12 cases of the false positive. So, and in this study, tumor markers has no diagnostic value. And this slide shows the result of the second screening. The first screening, we had a prevalence of the cancer. In the second screening, we can have the incidence of the cancer. So during the mean follow-up of the 1.2 years, cancer was diagnosed in 2 cases among 56 participants. So the incidence is 2.99 per 100 person year. The one is the pancreas cancer. So this is a very invasive ductal cancer. And second one is hepatocellular cancer. So this incidence is, I think, higher than I expected. So the incidence strongly suggests the necessity of the cancer screening in these populations. So this is conclusion of the cancer screening study for HIV-positive Japanese hemophiliacs. So FDG PET was conducted in 68 HIV-positive hemophiliacs with a mean age of 48.7 years old. And abnormal accumulation was found in 16 cases, and among them, the 4 cases are NADM. So the incidence was 5.9%. And during the mean follow-up of 1.2 years, cancer was diagnosed in 2 cases among 56 study participants. So the incidence was 2.99 per 100,000 years. So according to the result of the high prevalence and high incidence, we recommend the cancer screening, at least to the HIV-positive hemophiliacs in other hospitals. So this is a last slide, acknowledgement. Thanks to all staff members of ACC and HIV-positive hemophiliac participant in the cancer screening study. And special thanks to the Mikiko Ogata for her support to the cancer screening study, and Daisuke Mizushima for giving the data of his HPV-related study. Thank you very much.